Hi, everybody. Today we're going to be talking about the Therapeutic Alliance and the structure of therapy. And you'll be pleased to note that I have turned off the camera this time so you don't have the pain of watching me and I don't have the pain of watching myself. So I apologize for that last time. I'm recording on my laptop and I obviously did not change the settings. So, what is the Therapeutic Alliance? It's also known as the Therapeutic Rapport, and it's basically the relationship between the client and the therapist. So it's a fancy word for talking about your relationship with your client in psychotherapy. Um, the Therapeutic Alliance is the strongest predictor of outcome in individual psychotherapy across diverse treatment orientations and modalities. So basically, no matter what you do, whether it's psychoanalysis, CBT, whatever you do, whether it's an empirically based treatment or not, um, nothing is going to be a better predictor of outcome than your relationship with the client. And when you think about it, that makes sense because you can have a robot doing therapy with somebody, and while they may learn something, you're really not engaged unless there's some kind of a relationship there. And that's what makes people want to come back and really, make an effort. And when you're sharing your deepest, darkest secrets with somebody, you want it to be somebody that you can feel like you relate to, that is warm, empathic. And so that's such an important component of psychotherapy. And it's something that we often neglect to think about and talk about when we teach psychotherapy. So that's why I really wanted to focus on that today. So, what are the implications of this for psychotherapy? So, basically, for me, the implication is that you really cannot have good psychotherapy without a relationship. Many people think that empirically supported treatments, things such as, the Therapeutic Alliance, countertransference, all those things kind of go out the window because it's manualized and standardized, but that's not the case. Um, Using, a cognitive behavioral model, we very much highlight the relationship between the client and the therapist, and we think that that's very important, and we understand that the research shows that it's very important. So, there are some studies that show that up to 25% of change in psychotherapy is due to the Therapeutic Alliance. More recently, the numbers have been calculated differently, and I saw that it was much lower, back to about 7%. But that 7% is still the best predictor of outcome across the board, no matter what you're doing in terms of therapeutic modality, in terms of intervention, in terms of whether you're male, female, your ethnicity, your gender, etc. Um, so researchers have provided evidence that client ratings of the Alliance are stronger predictors of treatment than counselor ratings. So basically, you can think that you have a good relationship with your client, but if your client doesn't think that you have a good relationship, that means that the outcome of therapy is not going to be as good. So a lot of it really is figuring out how the client feels about, therapy with you. And one of the ways to do that is really to ask them. And as you go through the Judy Beck book, you'll notice that at the end of every session, there's a portion of time, usually about 5 minutes, where you talk about feedback. And that's where you kind of solicit to the client, how did you think the session went? Is there anything that we could have done better? Would you like to have changed anything? And that's so integral to therapy because if you don't address these things, it's like the elephant in the room and they just keep getting bigger and bigger. Um, until the client just stops coming altogether. So whenever you sense something is not up, is not right, it's very important to address that in psychotherapy. I know many of us, I'm kind of an avoidant person in my general relationships, but in psychotherapy, it's actually very counterproductive to be that way because, sometimes by avoiding things, things will pass, people's emotions, whatever. But in psychotherapy, it's always very important because I notice very often, let's say we're having a counseling session with somebody and I say something and I can see on their face that they either didn't understand it, they didn't take that well. So what I always do when I notice that is I say, I can see from your expression that something didn't go over well there. Tell me what was going through your mind. And then we address it right in the situation. And that can be very helpful and it avoids problems later down the road. So another thing that's really kind of important to note is that psychiatric symptoms do not predict therapeutic alliance formation. So, some people might think that because somebody has a very serious mental illness or a serious, very severe symptoms, they may not be able to form a relationship with you, but that's not the case. And so, regardless of the level of, symptom presentation or the type of disorder that's presented, you really need to focus on the relationship. And that's really what the first few sessions of psychotherapy are all about, is for you to get to know your client, but more for them to get to know you, to test you out, to see, what you're really like. And so we're going to be talking about some of the elements that you can kind of convey to the client during those first few sessions and obviously throughout therapy, but to kind of get them engaged and to keep them in psychotherapy. So, some of the factors that affect the therapeutic alliance are therapist experience. This is kind of debatable. So, we would think that people who have years and years of experience would be the best clinicians. And, in some cases that's true, because sometimes, just having somebody who's seasoned, who's seen it all, is a good thing. In other cases, either people just never had it to begin with, or they stopped caring. They're just, this has now become commonplace to them and they don't engage as much with their clients. And so, one review of 12 studies found a small positive relationship between therapist experience and the quality of the therapeutic relationship early in treatment. That was an older study, but more recent studies found that the therapist level of experience was not found to be predictive of patients' alliance ratings. So that obviously bodes well for all of you who are kind of in the naissance of your psychotherapy career. So that means that just because you don't have a lot of experience, or you don't even have any experience, it doesn't mean that you cannot form a relationship. Many of you have had customer service jobs where you've had to have relationships with clients, etc. And all that is very much integral. You've all had relationships with friends, family members, and you draw on that experience. What this leads me to think is that really it's not necessarily counseling technique per se, or your ability as a counselor. It's really your ability as a human being to bond to somebody else. And I think that there are people who are drawn to this profession who have those skills, and that's really what's predictive of the therapeutic alliance. So there's evidence from the attachment literature that suggests that the quality of a client's early relationship or family experiences may influence his or her ability to form an alliance early in individual psychotherapy. So if people had, good parenting skills, they had parental figures that they were attached to, that they, felt securely attached, um, then they are able to form relationships with the therapist, and that can happen early in therapy. People who have more insecure attachment styles, because they were more abused, neglected, or whatever, they didn't have somebody there early on in life, have a harder time bonding with their therapist, and that makes sense. I mean, if you haven't had that kind of experience, you don't trust a lot of people. It's hard for you to open up, to feel secure talking to people, and so we see that in psychotherapy as well. And that's challenging because the people who have insecure attachment styles are often the people who have more severe psychopathology or more severe problems in therapy, and therefore, you'll struggle more with these clients because you don't have that relationship, and that relationship is so integral in developing that trust in order to have them kind of on board and making the behavior changes that they need to. So how do you foster the therapeutic alliance? So this is some of the stuff that you're going to be working on in your first blog assignment, where you're going to be practicing, working on a therapeutic alliance with a partner, and then kind of getting some feedback on how that went for them, and then trying again and seeing if you can improve on some of those things. But a lot of these things in terms of fostering the therapeutic alliance really apply to your relationships in general. Like think about like when you meet people at a cocktail party, how are you drawn to some people? What makes you drawn to some people and not others? So being warm, friendly. So you have, if you see people have warm looks in their eyes, they smile, they're genuine. You feel like there's not the pretentiousness that goes along with that. That they're really forthcoming. That they're open, and that's open both in terms of your attitude, but also in terms of your posture. Because if you're sitting back in your chair with your arms crossed, your legs crossed, it's a very closed and kind of can be perceived as a hostile situation. You want to make eye contact. And again, we'll talk about in a few slides about cultural issues and how you have to take that into consideration. And eye contact may be one of them. Being empathic, and how do you convey that you feel empathy for the person? And that's through active listening, kind of repeating back what they say. I don't know if you watched those Rogers videos, Carl Rogers, back in your undergraduate psychology days, but he's the founder of the humanistic branch of psychotherapy. And what I really love about Rogers was he was a really great listener. If you've ever seen any tapes of him, and if you haven't had a chance to, I'd go to YouTube and just kind of Google him and see if you can see one of his therapy sessions, because he really just had this very, grandfatherly way of listening, and you really feel like you want to open up to him. And what it was is just active listening. So kind of saying, somebody says to you, I had a really tough day yesterday. My car died, and then I was late for an appointment, and I didn't get the loan at the bank, and I just really felt overwhelmed. And so, the therapist would sit back there and they would look at the person and they'd say, it really sounds like you had a rough day yesterday. It really was, something to that effect. You're kind of summarizing what the person said, and it sounds like you care. You're not actually doing anything in terms of psychotherapy technique, but you're really repeating back to them and being empathetic. Um, So these are kind of all things like, if you imagine kind of speed dating, if you had to, pick up a mate, these are all things that you'd want in somebody, in a friend and somebody that you'd be dating. So it's the same thing, I guess, essentially in psychotherapy. People are checking you out for these first few sessions and kind of trying to figure you out and see if that's a good match for them. You also want to demonstrate respect for the patient. And this is especially true in forensic settings, because oftentimes in forensic settings, offenders are treated with a lot of disrespect. I know that you always have to call them by their name, like Mr. or Ms. So and so that's supposed to be a sign of respect. But really, people are treated in many instances kind of, and I don't want to be, derogatory here, but they are treated sometimes like animals. And so treating them like human beings again can go a long way in really gaining people's trust and respect. And you also want to do that with your clients. Even if you have child clients, you want to treat them, as if what they're saying is important to you. Um, what are some of those other things that can help you form a therapeutic relationship? Think about what makes you feel comfortable around people. Like really, when I close my eyes and think of somebody who I would want to talk to as a therapist, I see somebody who is kind of, smiling, who, feels engaged, who is not looking at their watch every 5 seconds. Definitely you want to make sure you turn off your phones, your PDAs. Nothing would be worse than in therapy. You hear somebody looking at you, if you have your therapist checking their text messages or something like that. So all those things, convey respect and that you care about the individual. Asking questions, to clarify things that you don't understand. There are a lot of barriers to effective listening. And these are some of the things that we have to be aware of. These are, our own personal issues that can kind of hinder a relationship. So some things that are internal barriers are hearing what you want to hear. So, we often listen to what people are saying through our own experiences. And so somebody is talking about something that is, something that you've experienced. You may not hear exactly what they're telling you. You may try to interpret that in light of how you experienced it. And that's kind of, we'll talk later in the semester about working with, or in the semester later in this month, with patients with substance abuse disorders. And oftentimes substance abuse counselors are previous substance abusers. And that has obviously advantages in that they understand a lot of the struggles that the patients are going through, but it has disadvantages in terms of they're always interpreting the client's problems in light of their own. And so that's when they hear what they want to hear. That can cause biased listening. So if you have something that you're trying to get out of it, especially with offending populations, you want to make sure that you're trying to be as objective as possible, because part of the intake is really trying to get the person's side of the story. You may know something else about it, but their reality might be very different. Even if it's a distorted reality, that may be the reality that they've experienced. You may have hot buttons. So, if you have like mommy or daddy issues and the client starts talking about something like that, you may start thinking about your own experiences, and therefore it impacts your ability to listen to what the client is saying. A lot of these things can be surmised under or can be summarized under the kind of umbrella of countertransference, which traditionally has been considered to be a psychodynamic term, but we talk about it a lot in the cognitive behavioral world as well. And that's basically when we bring our own stuff to the table. and so that our own problems impact our relationship with our client, because some of the issues that our clients bring up are issues that we ourselves are struggling with. Like, you can imagine, like, we're all human beings, and if you're dealing with problems at home with your relationship, you have problems with your family, for instance, that can really impact your ability to conduct psychotherapy. um, I had a friend who was a mental health counselor, and she was seeing clients in the evenings, and she recently had a lot of stress in her personal life and her professional life, and she started suffering from depression and anxiety, and that was really impacting her ability to be there for her clients, to the point where she felt like she was actually not able to help them anymore, and she had to withdraw. And that's tough about being a psychologist, is that you or a counselor, is that you really have to be there and be able to give so much to your clients. And when you do have issues in your own personal life, then that definitely impacts them. A lot of people feel that in order to be a good therapist, you have to go to psychotherapy yourself. I'm personally not necessarily of this belief. I mean, if you have issues that need dealing with, of course, deal with them. I don't think that everybody has to go for psychotherapy. I think, that's kind of, left over from the psychoanalytic school, where you had to be analyzed before you could be an analyst. Some programs make their students go to psychotherapy. Most programs that are behaviorally or cognitive behaviorally based do not, but there are those services available for students who do need them. There are often physical barriers to effective listening. So, just thinking about the room situation, this is especially in forensic settings. Like, I've had to do therapy through glass windows, across tables, with guards in the room. So those are all impediments. You can imagine, like, with somebody else standing there making faces, because I've seen guards make faces when I've, worked with clients, how much that's going to affect your therapeutic relationship. There's semantic barriers. So, even I don't think that I use big words, but oftentimes, if somebody is not necessarily hasn't had, finished high school or whatever, they may not understand if they're speaking slang. I know people who speak Spanish, there are many different dialects, and so you also want to make sure that they're understanding what you're saying, and that you're coming across to them very clearly. There's also just generally the lack of training. And so, um, as a novice therapist, you're going to make mistakes, and that's okay. That's part of the learning process. But there's also kind of ignorance. And so we'll talk about being, culturally competent, and making sure it's okay to say, I'm not sure about that. I need to talk to my supervisor, or I have to go and research that or consult with a colleague. I would rather you say that than you make something up, because that does happen as well. And the client will definitely lose confidence in you because they figure those things out. There are also external barriers. These are some relatively simple things, but they can also impact a therapeutic alliance. So either you or the client are not speaking loudly enough. This is kind of frustrating when it's a client and you don't really understand them because they're mumbling or they're speaking very softly, and you have to keep repeating yourself. Um, or asking them to repeat themselves, um, somebody's mannerisms or appearance. So, you want to make sure that as a professional, you're always dressed professionally. If you're a woman, that your makeup is not too loud, your jewelry is not too loud, that you're dressed conservatively, that things that should not be showing are not showing, because that can be very distracting. Um, Also, that you don't gesticulate too much. And I know some people tend to use their arms more than others, but that can also be very distracting. And so when you do your therapeutic alliance exercise, make sure that you get feedback on some of those things, that this is something that you tend to do. If you're a person who says a lot, you want to make sure that those things are pointed out to you. I've had issues where it's hard to focus on your client, because I've had a few clients who've had, for example, schizophrenia, and have had very strange appearances. And so sometimes it's hard to get past that when you're working with a client. Like, once I had a woman, who had just crazy lipstick all over her face. And it was very hard to engage with her seriously. I mean, I did my very best, but I kept, focusing on that lipstick. It was very hard to get past that. Loud noises here in Manhattan, you want to make sure that as much as possible your office is soundproofed, if not use um, noise machines. But oftentimes you hear ambulances, noises going by, and they can be very distracting. You want your room temperature to be appropriate whenever possible, if you have any control over it. Sometimes I've been in prisons in upstate New York where there's no air conditioning. They're still very old, and in the summer months those facilities can get super hot, and it's very hard to concentrate when you're all sweaty and things like that. interruptions such as phone calls, as I mentioned earlier. You want to make sure that all your phones are on mute, that things don't vibrate, because even though and that your main phone ringer is put to straight to go to voicemail, that you're not fidgeting or clock watching. You want to make sure that you're on time, especially if you're in private practice, because you're going to be seeing patients every 45 minutes to every 50 minutes, and so it's integral that you stay on time. But you also don't want to be looking as if you're checking your watch at all times. So the ideal thing is to put a clock behind the person so that you can kind of look without looking. And if that's not possible, you have to then develop a way that you can check the time or monitor the time in a way that it's not distracting to the client. Because if they're telling you something very important and you're looking at your watch, that to them signals that you're not that interested in what they're saying. And then in terms of time pressure and deadlines, I think Judy Beck does an excellent job of kind of structuring the therapy sessions such that you're not really putting a lot of pressure on the client, kind of saying, we only have 45 minutes. This is what we can do. I know that you really want to talk about this, but we have 10 minutes left. How can we, what do you want to do about this? Should we start talking about this now, or should we table this and hold this off for next week? Because I can see that it's really important to you, and you leave it up to the client to decide. A lot of what we communicate is through our nonverbals. So even when we're not talking, we're still communicating in some manner. Like my husband, he's very, everything that he feels, you can see on his face. And I know when he's upset because I can see it on his face. It's good and bad. I know when he's not happy, but then sometimes, I kind of wish I didn't know he was not happy. So a skilled listener hears more than the speaker's voice. So pitch, rate, subtle variations in tone. So, if you hear people's voice cracking, things like that. Face color and how it changes. You often see people's face get flushed, movement of the lips, cheeks, eyes, eyebrows. If you're a person who's very expressive yourself, it's oftentimes important that you learn to control that, because sometimes your clients, especially in forensic situations, are going to tell you really shocking things. Or if you have patients with, psychosis, things that are kind of off the wall. Like I remember talking to a woman, she was in a study for patients with schizophrenia, but she seemed rather normal. But she was talking about her baby daddy, and then she was telling me that he was coming over and it was Bill Clinton. And clearly this woman's baby daddy was not Bill Clinton. But it was hard at that point not to have some sort of reaction. Fortunately, um, knowing that the person may have had schizophrenia, I was at least prepared for some things like this. But you hear very weird things sometimes, and it's very shocking to you. And sometimes it's hard not to laugh or to make a facial expression, and so you want to do whatever you can to kind of not convey that. It's also sometimes you feel disappointed, and that's normal. But like, for example, if you're working with patients who have substance use problems or offending populations, oftentimes they will relapse or they will do things, and it's hard not to convey a sense of disappointment in your face if they tell you something that goes against something you've been working on. So become aware of expressions that convey tension, doubt, trust, inattention, so forth, and so that you can try to modulate those as best as possible. So active listening techniques. So, these are the first and foremost things that you want to learn in psychotherapy before you even go into learning the different techniques. And these are listening and understanding non-judgmentally and non-critically. So as therapists, we're not here to judge our clients. There are times where your client is in situations where you don't think that it's a great idea, but you have to kind of help them and ask them Socratic questions so that they come up with the solution. And you don't want to be judgmental. I always hear people say, well, my therapist said I should do this. Well, a good therapist doesn't ever tell you what you should do. That is up to you to decide. A good therapist can show you the different choices that are out there, or help you look at the different choices that are out there, but it's really up to you to decide. And so you shouldn't be telling your client anything, because that's in a way judgmental by you saying, I know how somebody else should run their life. So you want to avoid solving the problems or thinking for them. Don't give advice. We are not advice givers. A lot of people think that's what therapists are. And there are a lot of therapists out there who do give advice, but that is not our job. We can provide them with research. Oftentimes I will give my clients journal articles. I will provide them with information that they may not be aware of, but I do not give advice. I leave them there. This is their life and they need to make the decisions. I just show them the different paths that they can take. Take your time and in terms of your responses and your questions. So you don't want to feel like you're barraging your client with questions. Um, the other day I was supervising one of the graduate students in our doctoral program, and she had a client that was given to her a few a few weeks before she was leaving the externship site. And so she felt like she had to make a lot of progress with this client. And so she, from day one, she was really pushing the client and asking a lot of questions to the point where in the second session, the client actually broke down and said, I feel like you're interrogating me. Um, and at which point, the student kind of stepped back and she said, you're absolutely right. I felt a lot of pressure and I'm really sorry. And at this point, the client decided not to continue with the student, and that's their right. And the student, it was a very valuable learning lesson for the student because she was using, there were external pressures for her, and she felt, that she needed to get a lot done in a short amount of time, and she was really neglecting the therapeutic relationship and not listening to what her client was saying. You want to maintain eye contact whenever possible. If your eye contact, you don't want to be like staring the person down, but at the same time, if your eye contact, is all over the place, or if you're not looking at the person, they think that you're not interested. Face the person with an open, relaxed posture. So this is really important when you're doing your therapeutic alliance exercise later on. And then acknowledge the speaker by nodding, leaning forward, making facial expressions that match the talker's feelings. So you want to, like, if somebody's telling you like a really sad story, you want to kind of, not in a fake way, but make kind of like, a sad face, like, oh, that must have been difficult for you. Or if they're telling you about something painful, you make the ouch kind of expression. It's basically showing that you're there with them and you're experiencing what they're showing, and that's really part of active listening. You also want to do more listening than talking. While CBT is an active therapy, you do want to make sure that you are listening to your patient. Now, you also don't want to let your patient kind of lead the session either, because sometimes people are just talkers, and I've had sessions where it's hard to get a word in edgewise, but it's very important that you still take control of those sessions, but at the same time that you let the client express what they're trying to say, and kind of, it's a delicate balance between reeling the client in and maintaining control while at the same time letting them express themselves. So responding to what is personal rather than to what is impersonal, distant, or abstract. And so really kind of talking to the meaning of the thing and the feelings that the person is experiencing. And restating and clarifying what the other person has said and not asking questions or telling what the listener feels, believes, or wants. So you want to really kind of reflect back what they're saying, and you kind of also want to reflect back the underlying construct so people can, talk about stuff and you can see that there's some underlying feelings of hurt. So sometimes I'll say, it sounds like a lot of what you're talking about is that this person really hurt you and that you're feeling hurt. Is that correct? And it's always good to check with your patient, because many times they'll say, that's not correct. Or they'll say, yeah, you're right, that's what I was feeling. So that's part of what active listening is. So trying to understand the feelings contained in what the other person is saying, not just the facts or ideas. And then working to develop the best possible sense of the other person's frame of reference while avoiding the temptation to respond from the listener's frame of reference. So, again, this is kind of seeing how the person feels and seeing the world through their goggles. And especially with offending populations, they're often going to feel like the world is against them, and you can understand why that is. And many times the criminal justice system is unfair. And even if that offender did something really horrible, you can understand that they're in that position many times because they've not had the best life, they've not necessarily made the best choices, but understanding that they're also human beings and they're experiencing hurt and pain and frustration as well. So even if you don't have a lot of empathy for them based on what they did to the victim, you have empathy for them as a human being, that some of the things that they're experiencing as a consequence of that are difficult for them to handle. You want to respond with acceptance and empathy and not with indifference, cold objectivity, or fake concern, because people identify that. Things to avoid, stereotype reactions, constantly repeating a phrase like, it's, you feel that, or you're saying that. So this is good feedback to get from your therapeutic alliance exercise. If you tend to say the same thing over and over again, try to vary that up. Pretending to understand. So if you get lost saying, sorry, I didn't get that, what are you saying? Um, you know, Oftentimes, and please don't tell my daughter this, but like you're busy and you're working on something and your child is telling you something, and I don't do this too often, but sometimes you don't really listen to what they're saying, and then you just kind of give them kind of a boilerplate answer. But you don't want to do that with clients. If they've said something to you, you want to, and you missed it for some reason, your head was thinking about what you're making for dinner that night, just say, I'm really sorry, I just lost you there for a second, can you repeat what you were saying? And sometimes the stories are just very convoluted and you just lose them anyway. Overreaching. So as I mentioned earlier, sometimes you're going to go, um, and interpret, and I don't mean like in a psychodynamic necessarily kind of way, but you're going to interpret the underlying feeling of what the person is talking about. So they'll be sharing new stories, and you can see that underlie there's some anger, some hurt, some frustration, or whatever. But I remember once my supervisor was was talking to me about a case where there was a nurse on the ward, and she was having a hard time, with this one client who was a lesbian. And my supervisor said, clearly this is the nurse's repressed lesbian tendencies that are acting out here. And it's like the nurse was married with children, and there was no indication that this nurse was lesbian or whatever. And not that there's anything wrong with that, which is obviously the common thing that everybody says. But there was no evidence for that, and she was completely overreaching in this case. And so you want to make sure that you're really talking about what the client is saying and not going above and beyond that, or some general things. And that's why it's really important to check with them. You also don't want to underreach where you're kind of missing the point. So somebody's sharing with you some really important stories, and you're kind of just paying attention to the facts and losing the underlying meaning. Long-windedness. After listening to this lecture, you may feel that I'm engaging in long-windedness at the moment. But you don't want to be doing a lot of the talking. The client is really the one who is going to be talking. Some people really like to hear themselves talk. I've seen a lot of those people. And it's important, there are times where you're going to have to be doing more of the talking when you're doing more of the didactic stuff and teaching them some kind of a new intervention. But on the other hand, you don't want to talk just to hear yourself talk, and that can come across as pretentious, and the client feels like you're not listening to them as well. Inattention to nonverbal cues, so facing or leaning away from the other, not maintaining eye contact, looking tense, or presenting a closed posture by crossing your arms. So make sure you don't do that. And so, even though you can say all the right things, if your physical body kind of is conveying that you don't care, people pay attention to that. So making sure that everything is kind of in sync with one another. Violating the other person's expectations. Giving reflective responses when they're clearly not appropriate. So somebody asks you, for example, do you have children? And that's a common, like especially if you're working with somebody and they're having issues with their children, it's a very common thing for people to ask personal questions like that. And some people feel not comfortable sharing that kind of information, and that's okay. But if somebody asks you a direct question like, do you have children? And you repeat something like, so it sounds like you're really concerned if I have children or not. Why is that? I mean, that can be very frustrating. It's like you just want to know if the person has children. Um, so, a better answer would be either yes, I do, or, I'm really not comfortable about discussing my personal life, which is appropriate, but at the same time can impact the therapeutic relationship. So you have to decide ahead of time what kind of information that you're willing to share. Um, you know, I usually will say, yes, I have children, if people ask. I don't go into a lot of detail, because it's really not, the therapy is not necessarily about me, but it helps people. Like I know before I was a mother, I often did, or not often, but I did do interventions with families who had children. I would do parent-child training. And parents would ask me, do you have children? I'd say no. And they're like, well, how can you do this if you don't have children? And I'd say, I've read the books, I understand, I've had training, and I did. And not to say that I wasn't able to be helpful to them, but now that I have children, there's a new level of understanding, this empathy that I can understand. Like, so as difficult, I don't think I understood how difficult some of these things really were until I had children. So if the person asks a direct question and obviously expects an answer, simply answering the question is often best. In other words, if somebody says, what time is it? You don't usually say you're feeling concerned about the time. Like that would just be absolutely ridiculous. There are a lot of multicultural issues and in terms of cultural competency when you think about therapeutic rapport. So cultural responsivity or sensitivity results from shared attitudes between the therapist and client, and is a better predictor of client ratings of satisfaction, empathy, unconditional regard, and therapy credibility than race. So there is some evidence that clients tend to do better if there's a race match, just because people feel most comfortable around generally. I mean, these are speaking in generalities and looking across studies on averages with people that are similar to them. Men generally feel more comfortable with men for the most part, women with women, generally, about the same age, and people of different racial and cultural backgrounds generally feel similar, more initially, they feel more comfortable with somebody who has a similar racial, ethnic, cultural, religious background than as they do. But that's just kind of as they walk through the door. Now, even if you do have, a different racial background than your client or a different religious background, that doesn't mean that you cannot conduct therapy with them. It just means that you have to try to understand where they're coming from, and they kind of have to feel you out. And so, the first few sessions may be a little bit rougher than if there was more cultural, religious, whatever match. But then, assuming that you do all the things that we just talked about and you're understanding and you're opening to hearing about their experiences and what their culture means to them, or their religion, or their their diversity, then I think all of those things can be overcome. And this becomes, especially salient if when you're working with people in the criminal justice system, because especially if you're not an individual of color, many of the individuals in the United States who are incarcerated are either Black or Hispanic. They're disproportionately represented in the offender population. And if you take my other class, we can discuss why that is and the whole inequality of that. But it is something that we have to pay attention to. And more than, race or ethnicity or religion, I think a lot of the stuff that's just going on is really socioeconomic. And I know talking to some of the offenders that I worked with, it was really just, you know, not that I didn't understand per se, but the abject poverty that they lived in, the abuse that they faced as they were children, things like that. I just had no comprehension of that growing up in kind of middle class suburbia in Canada. Like I fortunately never had to experience that. And so while you've seen it on TV and I really had to kind of listen to their stories and really try to imagine what that was like for them, because on a personal level, I fortunately never had to experience any of that stuff. And so really understanding where they came from and how that led them to be where they are today. Um, there is evidence that ethnic and language match is related to length of time in treatment, language match especially. I've had to do evaluations through interpreters, and it's very frustrating. So whenever possible, you want to get somebody who speaks the person's native language, because if you have to do any kind of therapy through an interpreter, you lose a lot in terms of therapeutic rapport because therapy becomes triangulated. There's research on racial dynamics in counseling suggests that therapists must be aware of how both his or her own as well as the client's racial identity affects the client. And so, your issues are going to be brought to the table as well. And so understanding how that may impact the client, and these may be conversations that you have to have with the client. In the assessment phase, ask them about their background, ask them what that means to them, what that role that plays in your life. I mean, somebody who is, a third generation um, immigrant may feel very differently than somebody who is a first generation immigrant. And those issues may be very different for different individuals in terms of their saliency. I think if you're in my other classes, you probably heard me talk ad nauseum about being from Canada. And when I first, and so you must think that I really, this is very important to me at this point. But when I first came to the United States about 10 years ago, that was such a part of my identity, was that I was Canadian, because, that was who I was. Now that I've been here for 10 plus years, I'm actually become an American citizen. Not that I don't care that I'm from Canada, but it's no longer such an important part of my identity. And I don't, some people who meet me today don't even know that I'm from Canada, although I've already talked about it like 10 dozen times in this class. So um, clearly it still impacts me to some degree. Now, it's inevitable that in your therapeutic relationship, there may be times when it's ruptured, which means that there's kind of like a disagreement, or the client gets upset by something you've done or said or not done. Um, but that doesn't mean that your therapy is necessarily done. If it does happen, don't despair. If you generally had a good relationship with your client at some point, it can be repaired. So it's just like any kind of friendship. If you had a friendship to begin with, if you have a disagreement, generally you can make up and it'll be okay. But it's really important to get information about what happened for this rupture in terms of your psychotherapy, because many times the psychotherapy dyad or dynamic is reflective of how people, um, you know, are in their personal lives, and how that impacts them. So you see that, especially working with people with borderline personality disorder, you'll see that a lot of the things that they're reporting in their personal life, like difficulties with other people, starts to manifest itself in your therapeutic relationship. You'll see that idealization of you one session, and then another session, they're very upset with you. You've done everything wrong, and so that kind of gives you information about how that person interacts in their personal life, and that can impact how the treatment that you provide them. So you want to find out, why did the therapeutic alliance rupture? Did you do something, say something? Is it something about the client? Typically, if a client has difficulty with therapeutic alliance, generally they have difficulty with other relationships in their life. So if they're getting upset with you, that's often probably what's going on as well. So it's a really important source of information. And then you want to look at what behaviors or events led to the rupture. I mean, sometimes it really may be your fault. Maybe, you were looking at your watch too much. Maybe you weren't listening to what they were saying. I mean, we all have off days or off sessions, and that's inevitable. But usually a lot of it has to do with the client and understanding that, and then that dynamic can add to the information that you have about them. Maintain dialogue with the patient and discuss feelings. Like, it seems to me that something has changed in our relationship, and have an open conversation about it. If they don't want to talk about it, you don't want to push it too hard, but bring it up again, gently. Um, if they keep coming back, that's always a good sign. Usually, if the relationship has ruptured, then they just decide to discontinue therapy. So, what I'd like you to do then would be to look at blog exercise number 1, which is in the information folder, and you guys are going to be doing a blog exercise whereby you're going to be role playing with somebody else, and you're going to be practicing a lot of these things that we just talked about in terms of therapeutic alliance formation. You'll then get feedback from your partner, whoever that might be, on how your session went, some of the things they noticed in terms of eye contact, posture, mannerisms, tones, all that stuff, things that you said. And then I'd like you to try to incorporate that into the second session and see if you can improve, and then blog about it and answer those questions that I've laid out for you, and tell me about your experience, and how you think that it went for you, what things you could improve, what areas you still need to work on. So now I'd like to talk to you a little bit about the structure of therapy. I've always loved the Judy Beck book for this, because it really very nicely conveys the structure of psychotherapy. So regardless of what therapeutic modality you use, I think it's really important to have structured psychotherapy. It's kind of like, I don't know if you've all had, and might be my bias because I like to be organized, but you've probably all gone to lectures where the professor doesn't have, for example, a PowerPoint presentation, and is just talking off the top of their head. And while there can be some really interesting information, that the lecture kind of typically goes all over the place, and you're left at the end of it kind of wondering, like, huh? And the same thing goes with psychotherapy. Like, if you don't have a structure to kind of design for psychotherapy, it can be difficult, and you don't have a sense of where you're going. And so I think that actually having a structure is very, very helpful. And I think Judy Beck really lays that out very nicely. So the first session is kind of the most pivotal session, both in terms of forming the alliance, but also kind of gathering information. This is when you're feeling each other out. And so you want to introduce yourself, talk about your degree, your training, your specialization. If you're a trainee, you say, I'm in the master's program, I'm being supervised right now, and this is what we do. Do you have any questions about that? Do you have any concerns? And have the patient have the opportunity to ask you any questions about yourself. And then my first question in therapy is always like, what brings you here today? Or if they've completed already an intake form ahead of time and I have it in front of me, I might say, I have all this information that you completed, but tell me in your own words, what brings you to my office today? Well, why are you here? And then you would review any intake forms that you have with the patient. In forensic settings, you may not have such forms. So, you play it by ear, and you kind of then talk about, maybe the agenda, if it's a structured intervention or things like that. But you want to review the patient history in terms of their symptom presentation. So if they're experiencing depression, how long have they experienced it? How many, how bad does it get? What are the what DSM type symptoms have they experienced? Is it lack of sleep, decreased appetite, the thoughts that they're experiencing? Do they have any therapy history? Have they had, previous types of psychotherapy? What worked, what didn't work? Who did they see, etc.? Why are they coming to you now versus somebody else? If there are any medical problems, this is really important because there's some disorders like thyroid conditions which can then result in depressive-like symptoms. And so by simply treating the thyroid condition, the depression gets alleviated. um, what is the family dynamic, who's kind of in the person's life right now, their social supports, and their kind of work information, just to get a sense of who they are and what their background is. You go over the informed consent. In the Blackboard folder, there are copies of informed consent forms that you can look at. There are lots of these on the internet, so you can Google a variety of different ones, but they have a lot of information in terms of what the client has to expect from psychotherapy. And then I also talk about fee structure and structure of session, etc., and the client's responsibility and the therapist's responsibility and confidentiality and all those issues. This is really important in terms of reviewing the limits of confidentiality, that if the person tells you they're going to hurt themselves or others, or if they report child abuse, that they know that you're a mandated reporter and that you have to then breach confidentiality. If it's a forensic situation, you want to talk to them about who the client is and what the limits of confidentiality are in those situations as well. It's best to be upfront. If you're working with adolescent clients, again, you want to clarify the nature of the therapeutic relationship with them, in that their parent is really the client. And so, you have to make an agreement with the parent as to what you do and do not report. That has to be conveyed to the adolescent as well. You also want to talk about the therapeutic modality and what the patient should expect from psychotherapy. So this, as you'll see in the Judy book, is where she kind of educates the client about the cognitive model. So I'll say, I'm a cognitive behavioral therapist, which means that, I talk to people about some of their thoughts and their feelings, and we work to alter some of those. And I usually give the example of, how our thoughts can influence our behaviors. If you've probably heard this example if you've taken any of my other classes, but, you're walking down the street and somebody looks at you up and down, and there are two ways that you can interpret that situation, and that will subsequently impact your behavior. The first one is that if somebody looks you up and down, you can think, wow, that person thinks I'm hot. And therefore you walk with your head held high, you feel good about yourself, and it ends up being a good day. If the same situation transpires and you think, wow, that person thinks I'm really ugly and they probably hate my outfit, then you're kind of, you're more feeling down on yourself, your shoulders are slouched, and your day is not going to go nearly as well. And that's all based on your interpretation of the event. And so that's, how cognitive therapy can kind of work. I'll also kind of show them a diagram of the ABC model and go over it with them a little bit. Some patients know about it, they've researched it, and they're coming to see you because you're a CBT therapist. Other people have no clue. I have people come and, what they know about psychotherapy is what they see on TV, and they lie down on the couch and they feel more comfortable that way, and that's fine, and that's what they expect. We'll talk about the structure of sessions, generally about agenda setting, how we're going to go over different things, ask what the client is expecting, make sure that the expectations are realistic. And you can also provide additional readings. So oftentimes if the individuals have different disorders, I might provide handouts, telling them a little bit about the disorder, and, if they don't have a lot of information about it already, just educating them a little bit. We'll also develop a goal list for therapy, and these lists may change as therapy progresses, but you want to make sure that you have different treatment targets. Write that down, and you want to reassess those every few sessions to make sure that's still the case. You'll also want to prioritize them, and such that you can, you go from the issues that are most important to the client to the issues that are less important. And you also want to leave the client feeling hopeful for change, saying, I'm really confident that if we work together, we can work to reach some of those goals. I think they're very attainable. And the research suggests that really is the case. You're not making false promises. We're not going to tell somebody who has, for example, a persistent mental illness that will make their illness go away, but we can help them manage some of those symptoms. Note taking. This is kind of a question that people have. Should you take notes during the session? What's the contents of the notes? So we do and we should take some sort of notes. You don't want to write very personal things in those notes because if those notes are subpoenaed, then that information can be let go. But what you want to do is have enough information down that you know what's going on. Because if you have a caseload of 40 clients, and especially if you don't see the client every single week, you're going to forget what's going on. It's also important to write down key names, like of significant others, so that you know who they're talking about when they're talking about Bill or John or Bob or Mary or whatever else, and what that relationship is to that person. Generally, what I do in my session notes, and there are again samples in the Blackboard folder, is I'll put the patient's ID number, the date, the results from their self-report questionnaires that they usually complete before session. I will put the agenda items, which we talk about at the beginning of the session, and then just some brief notes. We discussed this, we reviewed this, blah, blah, blah. Then I'll put down what we have assigned for homework, and anything else that I may feel is important. There are two different kinds of notes. There are progress notes, which are part of the client record, and psychotherapy notes, which are not part of the file. So psychotherapy notes are much more personal, and I think these are historically, people with more dynamic orientations took more extensive notes. Now, I think in terms of timekeeping, people don't take such extensive notes, and a lot of people, and I'm one of those people who do not take two separate sets of notes. So the stuff that I write down, I put in the file. And I take my notes during the therapy session. If you kind of, you know, indicate that people actually like that you're taking notes because it shows that you're paying attention to what they're saying. And it also saves you time because I usually, when I was in private practice, I would see patients every 45 minutes and I wouldn't have time between sessions to take notes. And at the end of the day, you're not going to remember at 5 o'clock what your 9 o'clock patient said to you. I mean, when you've seen 7 or 8 patients in between. So the best practice is to just get used to taking very simple notes during the course of your session, such that at the time when your session is over, your notes are complete and you can just file it in the record. So what goes in the client file? A record, contact information, informed consent for treatment, including notification of rights, an intake report, a written treatment plan, progress notes, which, depending on where you work, they require those types of progress notes, termination note when work is completed, other materials such as releases of information, task protocols, information obtained from other sources. So if you've gotten records from their psychiatrist, etc., those all go in the client file. The file record does not contain psychotherapy notes. So if it's not in the client file, it's not considered a psychotherapy note. So psychotherapy notes, there's been some debate whether clinicians should have these. These are really only for the therapist to see. This is where you have your impressions of the client, etc. One of the few substantive changes that's been brought about by HIPAA, which is the privacy notification that everybody now needs to sign, is that psychotherapy notes are defined and they're protected from normal releases to the client, the courts, or anyone else. So psychotherapy note means that notes are recorded in any medium by a healthcare professional who is mental health professional documenting or analyzing the contents of a conversation during a private counseling session or a group. And they're separated from the individual's medical record. Psychotherapy notes exclude medication prescription monitoring, counseling session start and stop times, the modality and frequency of treatment furnished, results of clinical tests, and any summary of the following items: diagnosis, functional status, and treatment plan. So basically, all the stuff that kind of is the nuts and bolts goes in the file. Other stuff that's more like the process work can be held separately. Then another section of the law gives individuals almost unlimited access to their records, but specifically excludes psychotherapy notes as defined above. So the key element of this definition is that psychotherapy notes are produced by a mental health professional, are separated from the rest of the medical record, don't include the basic treatment and record keeping that goes in standard progress notes, and are not open to disclosure to the client or anyone else. Basically, this takes a lot of time and effort, and to me, the benefit is minimal. So, as I said, I do not maintain separate notes. However, some people really like to do this, and it's I guess a personal decision whether you're going to do this or not. You then also have to maintain for the confidentiality of these psychotherapy notes should anything happen to you. So progress notes are the notes that are part of the regular file maintained in the clinic or the facility where you're working. Um, and because many of the functions of notes for the purposes are for the treating clinician can be accomplished with the psychotherapy note, progress notes contents are kept to a minimum. So the following types of information goes in progress notes: counseling, stop and start times, medication prescription and monitoring, the modality and frequency of the treatment furnished, results of clinical tests, and any summary of the following items: diagnosis, functional status, symptoms, prognosis, and progress to date. So who is the audience? Um, you, the therapist, will look back at the notes as needed. The client or patient may want to look at the notes and has this right under HIPAA. Another therapist who picks up the case, and especially as trainees, you're going to probably transfer cases, especially if you're seeing clients with persistent mental illness, or even in prison. Many people are there for many years. You're not, people change jobs, they leave, so they're not always going to be the person there. So you want to make sure that somebody can look at the records and understand what happened in psychotherapy. An evaluator for another agency may review therapy notes with the client's permission, and then an attorney representing your client or an opposing attorney in a legal proceeding. So first, keep in mind that your task in a progress note is to document that reasonable work occurred toward the goal of helping your client with their issues. And so all that can be very easily documented in the way that I've described already. The note can be brief, really just a summary of what's going on. You want to assess, the client's status on the note that I've given you in the sample. There's really just like a Likert type scale where you can check how much progress was made in the session, and leave anything longer for your psychotherapy notes if you feel that's necessary. So where are notes kept? In general, progress notes will be written immediately following a session or during a session, as I discussed, will be kept in reverse chronological order in the client's file, locked in the appropriate drawer in the clinic or wherever your therapy is taking place. The client's file may be removed only for the purposes of writing and reviewing notes and replaced when you're finished. Psychotherapy notes must be kept separate from the main file. So there are different types of progress notes. The two main ones, and some of you who are already working in settings may be familiar with them, are SOAP notes, Subjective Objective Assessment Plan, and DAP notes, Descriptive Assessment and Plan. I'm not going to go over these in too much detail because, from site to site, these vary extensively. Just be aware that these types of notes exist. And how to go about, assessing them or writing them. You're going to get training on this no matter where you are. Some people require a little more practice in getting the notes right. People are very particular about how they want the notes done at their facilities, and so make sure that, you spend some time reviewing other, therapist notes to understand that you're doing them correctly. So the descriptive part of DAP provides information as to who was involved, where and when a significant event occurred. It's also a description of an issue of personal importance. The response is what you did after listening and observing and reflecting. The assessment part is understanding what the event means. If you know, think about how the event or behavior relates to this precipitating factors, to previous behavior, other events in the client's life. And then the last part is the treatment plan, and that's kind of what you're going to do. So it might be as brief as scheduled therapy for next Wednesday, or it may be, assigning homework or something like that. So this is an example of a DAP note, and I believe there's some in your Blackboard folder as well. So Jiminy Cricket, date, 1 hour, client attended and took. This is especially if you're doing groups or forever. Many times you have to do brief notes for every member of the group. If you had 12 patients, it can take a while. So you see that they're very brief. So client attended took part in group today, second day in group. Client reports fears of losing wife and job if he does not get sober. Reported fear that he'll be unable to remain sober. Reports 4 days of sobriety. So these are very objective. The A part is the client's, this is where you're kind of doing the assessment. This is your subjective kind of opinion. And then the plan is, continue with current plan or attend psychotherapy next week. And then you sign it with your credentials. The SOAP is very similar, just slightly different format. It's more used in medical settings. So it's the subjective, what the patient is reporting, the objective, like blood pressure, lab results. The assessment is the clinical diagnosis, and the plan is the prescription treatment recommendation. You'll see it a lot in, as I said, in hospital settings and sometimes in forensic settings. Here's an example of a SOAP note. Again, we're doing the date, the time, the client name and number. S, the client came in readily to the meeting room and indicated he had a great deal to talk about today. He identified that since our last meeting, he had followed through both his homework assignment and he had attended a group. So this is the client's perspective. The objective is as the client shared his feelings. This is your opinion of what. So the S part is the client's opinion. The O part is your opinion. The A part is the assessment, and the P part is the plan and what's going to happen. So just to end this lecture, we'll talk about termination, which is very apropos as the lecture is about to end. It's very interesting that about 60% of clients in one study felt that therapy did not end at the appropriate time. 37% felt it was too early, and 23% felt it was too long. So that's really important. It's very hard to find the exact right time. For many people, psychotherapy, it's a relationship, and it's hard to end relationships. And people sometimes, even though you don't want them to, become dependent on you, especially if they don't have large social support groups. That's why it's always important to kind of try to get patients to develop larger support groups. Well, as other people, sometimes people will just want to leave therapy. So you want to make sure that you're trying to end the best part possible. So termination is generally viewed by psychotherapists as a complex stage of psychotherapy, and there are a lot of issues that go into that. And research confirms that during this phase, the progress and process of psychotherapy are typically reviewed, goals are developed for the future, and the dyad says goodbye. For some clients and psychotherapists, psychotherapy termination is also theorized to trigger re-experiencing of past loss and unresolved grief. So be prepared that sometimes your clients might have very difficult reactions. Like, some clients get very angry as closure starts. I have an extern right now that I'm supervising, and she'll be leaving. It's a different extern than I mentioned earlier. And she'll be leaving her placement in a few weeks, and so she prepared her clients about 6 weeks out that she's going to be leaving because some of them are going to be transferring. But she's had a few clients who've been, they stopped coming as frequently. They didn't return her calls because they were angry with her. They felt very close to her, and they felt like she was abandoning them, even though they knew at the onset that she was an extern and that was going to happen. When the time comes, it can be very difficult when you become very close to somebody. And she's actually viewing it, she's feeling very kind of sad about the whole process. While she's happy that her externship is ending, she does feel a little bit like she's abandoning her clients, and that's a very typical way for a therapist to feel. Termination primarily reviewed for short-term psychotherapy. We don't know so much about long-term psychotherapy. So as you'll see in the Judy Beck book, termination is talked about right from the very beginning. So you kind of talk about this as being a time-limited intervention. There are not going to be that many sessions, so the client is much more prepared. Where there is very little evidence that clients are traumatized by termination. In many instances, clients actually are happy because it often means that, that they've made progress, they're feeling better, and they're kind of ready to go on. And research also suggests that patients see it as a growth opportunity to go out and practice new skills on their own. Sometimes you might want to taper down therapy, so you're seeing them kind of like every other week for a while, then once a week. And by that time, the client's kind of, ready to terminate on their own when they're only seeing you about once a month. Research suggests that most clients, about 70%, appreciate the opportunity to discuss their reactions to the psychotherapist. So talking to them about the process and saying, how do you feel about this? How do you feel like this, that our therapy is coming to an end? And it's very reasonable to talk about it. Again, there are some losses, there are some gains, there are advantages and disadvantages. When surveyed about their reactions to terminations, clients most commonly identified a variety of feelings, including pride, health, a sense of accomplishment, independence, cooperation, calmness, alive, agreeable, friendly, good, healthy, thoughtful, and satisfied. So these are all very positive feelings. So, more often than not, clients are going to feel good about terminating because it means that they've made progress and they're in a better place than they were when they started seeing you. So it's important for psychotherapists to be aware that these positive feelings are the ones that are most commonly identified, because I know if we think too much of ourselves sometimes, but we're often too aware that it's not going to go well. And so we expect our clients to feel more negatively to termination than they actually do. The most highly rated psychotherapist reaction was pride, both in terms of the client growth and their therapeutic skill, because you should feel good that your clients feel good about termination. It means you've done a good job, that they're feeling strong enough to go out on their own, kind of like you're a mother hen and you're letting your chicks go free into the world. Um, the importance clients placed on discussing their reactions to ending has been significantly related to client loss history, as well as loss as a theme in psychotherapy. So for those that have had a lot of history of loss of relationships or death or things like that, ending therapy may be more difficult, and it's important to expect that and anticipate it and discuss it kind of as one of your goals in psychotherapy is how to handle the termination of psychotherapy in general. And it appears as though clients with loss as a predominant theme may experience termination both as a crisis and, when appropriate, giving appropriate clinical attention, and opportunity for development. So all the things that you're practicing with your client, this is a really good opportunity for them to kind of use those skills in vivo and actually handle it. And in terms of deciding when to mutually terminate, one set of authors, Rowe et al., found that clients reported initiating these discussions about 2/3 of the time. In CBT, it's usually more the therapist that discusses it because it's more of a time-limited intervention, but patients also discuss it as well. It's important, as I said, to from the onset have this as an item that is discussed. The most common reasons for termination are accomplishment of goals, situation or external factors, and dissatisfaction with therapy. Interestingly, a discrepancy was found between clients and psychotherapists' view, with almost twice as many clients attributing termination to a successful achievement of goals. So almost 40% versus 26%. So how do you terminate? So start talking about termination in session 1. As I said, you're going to say this is a time-limited intervention. I expect that we'll be together for about 15 or 20 sessions, or about, based on, this may vary obviously, but that's generally what we find with people with problems that you're talking about. Give the client the expectation that when goals are reached, therapy ends. So as I mentioned in the last lecture, I know there are some therapists, because this is their bread and butter, they keep clients on kind of indefinitely, because when they lose a client, they lose an income stream. But to me, this is an unethical practice. And I mean, while we all have things to work on, therapy is very expensive, especially if you're doing private practice. And so it's not necessarily appropriate to keep people on longer. It also fosters dependency, and you want to make sure that, just like if you have a child, you want to let them, explore and discover on their own. You want to let that happen to your clients as well. You want them to, sometimes they'll come back, and that's fine. They might need some additional help, but you want to give them the opportunity to try these skills that you've been working on their own. You want to frequently review progress towards your goals with the client and kind of rate where they think they are. Reinforce treatment as a success and not as a loss necessarily, because it means that as you terminate, if termination is a success, as you terminate, it means that the client is feeling better, that things are going well, they've done well. And then when client is close to reaching their goals, to decrease the frequencies of the sessions, as I mentioned earlier. We want to openly discuss feelings of termination with our client, set a termination date together, and always leave the door open for patient to come back or call if they need booster or return to therapy. You can say, I'm always here. You have my number. Feel free, if things, if you start, just to experience some of the things that we talked about in your relapse prevention plan, to give me a call, and I'm happy to see you, even if it's just for one session to get you back on track. But you know that my door is always open to you, and have that relationship. There's also a termination when therapy is not going well. Sometimes it's not going to be working out and you have to terminate. So you need to address the progress of the client. You can say, we've been working together for 10, 15 sessions now, and I don't see a lot of change in your scores, and you're still reporting a lot of difficulty. What do you think's going on? Ask the client about their opinion of progress. I mean, you may have very different views. You might feel like the client's not making a lot of progress. They may view it differently. So say, how do you think therapy is going for you? Ask them to solve the problem. So you say, I noticed that the scores are not going down. What do you think's going on? How do you think that, what do you think we can do differently? And if all else fails, indicate that perhaps it's not a good match or it's not working out. You can say that, we've worked together now for 15 sessions and we've tried different things. We've tried to problem solve, but it seems like, they're not making a lot of progress towards their goals, or they're not making the progress that they hope they want to make. Is this maybe time for them to try something else? To maybe there's something, about the relationship, and really leave the decision up to the client. And so you wouldn't do this after session 1 or 2. You try to do a lot of problem solving. But if you try a lot of different options and you're still not making a lot of progress, this is where you really need to address it and see what the client wants to do. If they want to continue, then you do